Class, I have this case study in front of me, and this is also downloaded in your Canvas course under week 5. And I'm just going to take you through this so you can start to think about the things that I talked about in the previous lecture when it comes to anatomy and physiology, and now looking at some different kinds of assessments made on a patient who has a very definite respiratory problem. This is Mr. Winchell. He's a 70-year-old Caucasian male. He's been admitted to the inpatient medical unit with acute respiratory infection. The nurse prepares to complete the patient's admission assessment after his transfer from the emergency department. And his chronic diagnosis of emphysema or obstructive lung disease is quite obvious as we look at this patient sitting here in the chair. And my first question to you is, what do you notice as part of your general survey regarding the patient's overall appearance? I mean, what kind of initial visual assessment would you make on this patient as you walk into his room and see him sitting in a chair? Obviously, he's a male, and you can tell that very, very thin, somewhat emaciated. You can see all his definite features with his bone, his rib cage. Arms are very thin, frail. Notice how he's kind of leaning over. Many times patients who have this problem with chronic obstructive pulmonary disease will tend to kind of lean forward to kind of hopefully open up that area in the lungs to let in more oxygen. Obviously, you haven't had the pathology on someone who has this problem, but one of the main features or manifestations of this disease is the fact that they retain CO2. The pathology lies in the alveoli. It's very damaged. There's poor exchange of gases. Oxygen levels are very low. They live in a chronic state of hypoxia, and of course they're CO2 retainers. So their CO2 levels are very high. And remember, if we go back to the anatomy and physiology of how our lungs work, remember that statement that I made in one of the previous videos I have for you is the fact that the desire and the drive to breathe is based on CO2 levels. And because his are high, the brain is constantly telling this patient to breathe because no matter how much that patient breathes with this disease process, they're never going to be able to blow off all that CO2 unless sometimes they're put on a mechanical ventilation, which at this point this patient doesn't need. But this is a very common problem we see in these types of patients. Very vulnerable to infections, especially respiratory infections, and they do come into the hospital frequently, especially this time of the year, with an acute respiratory infection. And what happens is they're at home, they start to become even more short of breath, really unable to do many of their activities of daily living, and they're not eating, they're probably not drinking, they come in with somewhat of dehydration. They probably don't eat and drink a lot as it is because of their progressive and end-stage disease. It takes a lot of effort to eat and drink, so they finally come into either the doctor's office or to the emergency department because it's their last resort. They really just need to have some relief and some way in which they can breathe somewhat. He doesn't have oxygen on at the moment, but you can see his color is kind of pale and ruddy and red. So overall, we know this patient is in some acute distress. And our goal is to try to get him to his maximum level of the way in which we can oxygenate him. Now, he looks like he's probably had this disease for a long time. So, we may never be able to get that PCO2 down or even get his PaO2 up unless we put him some high concentrations of oxygen, but which we can't do. We've got to be very careful of, because remember, that's his desire to drive and breathe. We call that his hypoxic drive. So they are in a state of hypoxia all the time with a retention of CO2. So let's go through these questions, and I really want you to think about these, and all the answers are based on your readings, how we assess the respiratory system. So please, if some of them you don't really understand why the answer is the answer, I'll explain a little bit of it, but then you may want to go back and star that question and go back and read that particular area in your book or in your D'Amico and Barbarita book for assessment. This isn't easy. I never said it was, and I told you that this is a very challenging system, so I really want you to understand this, because it's not only making that assessment, but also understanding the whys of why that patient is presenting the way he is. Most of the answers, if not all the answers, are in your book, but if there's anything I can help you with, let me know. These are the types of questions that would be on your test coming up. I also want to advise you to download an app from ATI. It's called RN, capital RN, space Mentor, MENTOR, from ATI. Google it and download it and put it on your phone. It's a wonderful app from ATI. I just found out about it last week, and you'll have it at your fingertips, so that if you're in an area or waiting at a doctor's office, or you have a few minutes, you can go on this app on your phone and just practice and do some more NCLEX style questions. I went on it a little bit on Friday, and it's a very, very good app. Some of you have been emailing me and asking me, is there any type of website I can go on to practice NCLEX style questions? Well, I'm giving you one that's absolutely free. It's a great website. It's called RN space Mentor, MENTOR, and just put -ATI, and you'll be able to download it on your phone. It's absolutely free, and it really is good, and you'll see all the various categories, and you may want to hit fundamentals of nursing and practice some of the NCLEX style questions. So please, if you have any questions about that, let me know, but you should be able to download it easy. If I can do it, you definitely can do it. All right, so let's go through these questions. Some of them may be easier than others, but I just want to kind of go through it with you. Would have done this with you in class today, so let's continue. Okay, for the first question here is, to ensure that the patient's respiratory status is stable upon arrival on the medical unit, which assessment should the nurse complete first? And I'm not one about doing things in order, because a lot of times when these patients come in, you might have a couple nurses come into the room, because these patients will be in somewhat of a respiratory distress, and a couple nurses are in there doing things for the patient to get them more comfortable and making assessments themselves. But really the first thing we're going to do is do an O2 saturation. We want to just see where this patient is at, and probably in the emergency department they've done a lot of labs. They've done a chest x-ray, they've done arterial blood gases, but you want to see what this patient is presently for you, so you'll do an O2 sat on him just to kind of see where he's at. You may not get a high number. It's something that, you know, is concerning, but you have to look at the nature of the patient's disease. This may be as high as this patient can ever get. These patients eventually will die from respiratory failure. So sometimes it's nice to chat with the doctor, because they know these patients, they've been treating them for many years, and sometimes it's good to know that that as a nurse we would definitely kind of confer with the doctor to see, you know, what's the best I can get this patient's O2 sats at, you know, and that's what you need to know, because sometimes nurses, you know, might get all stressed and bent out of shape and go, oh my God, his O2 sats not any higher than you know, 90% or 91, and you know, we as nurses know that's not in a good range, so we kind of think, okay, what are we going to do? But this is maybe the best this patient can be. So that's the first thing we definitely want to know, and we want to see if that O2 saturation really kind of correlates with the way the patient presents. So hopefully that makes sense. The nurse measures the client's vital signs. His respiratory rate is 32 breaths per minute. What follow-up assessment data should the nurse obtain first? Okay, he's breathing about 32 breaths per minute. So right now, as the nurse, remember, go back to that list that was on the PowerPoint that helps you determine, what is the normal range of an adult and how many times a minute should they breathe. Wasn't it something like 15 to 20? So his is up to 32. So he is a little bit tachypneic. Remember, that's the formal word for increased respirations. So he's breathing a little bit fast, which would make sense. He's got an infection, so you would definitely expect that. So what follow-up assessment data should the nurse obtain first? And one thing that we look at is the use of accessory muscles, because normally when we're not in any distress, we're not using our accessory muscles to breathe. But in this case, this gentleman is, because think about all the muscles, this even says this in your book, that are used for some patients that really need to breathe. Let me give you an example. You, for instance, might be very healthy, have no indication of any respiratory distress, and so you go out and you run a marathon or a 10K. You're giving it your all, you're trying to cross that finish line, and think about it. What do those people look like when they're crossing that finish line? They finish the race, and what do you see a lot of them doing? They're bending over, they're breathing very fast, and they're using their accessory muscles, their back muscles, their chest muscles, their diaphragm, to get in as much oxygen as they can, because they're trying to keep oxygenated, because you need a lot of oxygen to be able to meet the demands of running that race. But that's a perfectly normal response. But with these patients, because of their disease process, they also need that extra oomph to help them breathe. So we look at those accessory muscles, and that's another indication that your patients are in extreme respiratory distress. If you see them really heaving and really, seeing that chest really rise and fall, and they're using those back muscles and those shoulder muscles to breathe, you know that they're in some distress. So that's how we kind of maybe assess the level of what kind of respiratory distress these patients are experiencing. We know he has a cigarette smoking history. We read his history, and we know that his emphysema is due to the fact that he smoked, 2 packs of cigarettes or 3 packs of cigarettes for the last 40 years. Cultural health beliefs are not going to affect, how fast he's breathing, and the color of sputum is not significant right at this moment. Yes, it could indicate what type of problem the patient has by the color of sputum, but for now, we really want to look at how much of those accessory muscles is your patient using to breathe, okay? I hope that makes sense, but go back to that one section in your book that talks about muscles for inspiration and how important those muscles are, especially our diaphragm, okay? So look at that, because that's really very important in the normal respiratory and ventilation process, okay? Hold your hand on your own diaphragm and take a deep breath and see what happens to the diaphragm as you take a deep breath in and as you take a deep breath out, okay? So think about why your patients would have compromise when they breathe if they've had some damage or some spinal cord injury that affects the diaphragm. Their respiratory effort is going to be either decreased, minimal, or not exist at all, and that's why sometimes people that have spinal cord injuries, when it affects the diaphragm, may be on some artificial means of mechanical ventilation because that diaphragm is not working anymore. Remember, the diaphragm is a muscle, and so when you don't have that nervous intervention to that muscle, that diaphragm is not going to work at an optimum way, okay? All right, let's go to the next question. The nurse applies oxygen at 2 liters per minute via nasal cannula and ensures that the patient is comfortable. So his O2 sat is stable at 95%, and his respiratory rates now went from 32 to 24. So he reports that he feels able to continue with the admission interview and assessment. So after answering a few questions, the patient begins to cough. What assessment should the nurse perform? So as you make that assessment, you can see that the oxygen really was a very good thing to provide for the patient. just enough where we got his O2 sats in a normal range, and you can see now he's in a little bit less distress because his respiratory rates come down from 32 to 24. So we're really happy with that, but now he's starting to cough, which may again interfere with us asking him questions about what happened, what brought him to the hospital, and kind of other things that we need to know at this point. So what kind of questions would we begin to ask him now that we know that he's beginning to cough? So look at our choices. So hopefully you can have a good idea, but now that he's coughing, we want to see if he's bringing up any sputum. So this is the time we would assess, is this a non-productive versus a productive cough? And if it is productive, we want to definitely note and document the color, the amount, the viscosity, because this is huge. Because remember, if we go back to our initial assessment and normal anatomy and physiology, we talked about some of the barriers that lead to alterations in oxygenation, and one is sputum. And many of these patients with their history of COPD, along with the infection that's present, many of them will have sputum issues. So as I said before, if there is sputum, just go ahead, tell the patient you need a specimen and get it, and get the order to send it down, because various colors in sputum, whether or not it's white, yellow, brown, gray, pink, all those could indicate some very significant problems and diagnoses with the patient. So definitely document this. Plus, you know, if it really is a big problem for the patient later on, that maybe the production of sputum starts to increase, we may try to provide medications or respiratory treatments to kind of decrease that viscosity, because sometimes that's the problem. The sputum is so very thick. These patients are exhausted. They're extremely tired, and it has to give a lot of effort to get the sputum up. Please make sure if they're not eating or drinking and they're bringing up a lot of sputum, that you're doing good mouth care on these patients, because think about it. The taste of that sputum in their mouth really provides them absolutely no appetite. Make sure they're drinking enough. And make sure that his tissues, if he has them at the bedside, are provided for him, as well as a place to throw away. You don't want to see a lot of tissues on your patient's bedside that have a lot of gross sputum. It's just not very conducive to a pleasant environment. Plus, if it does have pathogens or organisms in it, we definitely want to keep those away from the patient. Because of this sputum and what comes back with this culture and sensitivity, we may have to put these patients on an antibiotic. So sputum is huge, and it can tell a lot about your patient's health. Okay, right now we see that Mr. Winchell's cough is non-productive. After Mr. Winchell stops coughing, the nurse continues the interview to assess the patient's history related to dyspnea on exertion, and we might see that as an acronym of DOE. What question would the nurse ask Mr. Winchell? And the answer to that would be B. What activities cause you to feel short of breath? Okay. Definitely he's going to be short of breath if he lies flat. That's pretty obvious. And remember, we want to get more information from this patient if he's able to do so. Sometimes just talking will really fatigue these patients quite a lot. So we want to know what is it that caused him to get more shortness of breath. And all these questions, like, are you having trouble catching your breath right now? I mean, if he is, we wouldn't be continuing with that, so we can kind of tell whether or not he is having problems answering the questions. And that's another thing, as you're continuing to ask this patient questions. This is a respiratory patient. You need to make a good assessment whether or not this is a good thing to continue with this kind of interview, because if it's wearing this patient out and you can tell that he's really not giving you the answers you need, you might want to come back, let him rest a little bit, and then come back and answer those questions at another time. So make sure you're doing that. Think about the patient. He comes first. So the answer to that is, what activities cause you to feel short of breath? All right, the next one is the nurse asks Mr. Winchell about his history of cigarette smoking, and he tells the nurse that he smoked 2 packs of cigarettes per day for over 40 years, but then he quit smoking 10 years ago. And how do you record this smoking history? Remember now, he's looking away and remarks that he's very fatigued from answering all these questions. So what are you going to do? And this is, again, brings up a very important point. You are going to look at these choices and just tell him to rest in bed while you do your assessment on the patient. The patient doesn't even have to speak. You're going to do all the work, and that's the important thing, that you're continuing to make your assessments. You're looking at, listening to maybe breath sounds. You're assessing his cardiac status and things like that. So you wouldn't continue the interview and assessment. You wouldn't restrict visitors, but you would just advise the patient to rest in bed, just lay there. I'll do the rest of the assessment, and we'll talk later on, okay? So that's the answer, is C, all right? All right, now the next question. While Mr. Winchell rests, the nurse continues the physical assessment. The nurse observes the appearance of Mr. Winchell's thorax and notes that the ratio of his anterior, posterior, and transverse chest diameters is a 1-to-1. How should this findings be documented? This is in your Barbarita. I told you to look at that because now we've got a patient that has a barrel chest. Why does a barrel chest happen? This is something that doesn't happen overnight. This is something that progressively begins to occur over many, many years. And the reason a patient gets a barrel chest is, I'm not going to tell you. I want you to find out why, and then I'm going to come back on Wednesday in class and ask you to tell me why a patient develops a barrel chest. What's the pathophysiology behind it? So I'm marking that down. I want you to kind of do a little soul searching and find out why the patient with COPD or emphysema develops a barrel chest over many, many years, okay? And we'll get back to that. But the answer is barrel chest, okay? This is, again, knowing the anatomy and physiology. What is the normal anterior, posterior, and transverse chest diameter supposed to be on someone who is disease-free, who has a normal, chest area? So we'll get back to that later. All right, the nurse observes Mr. Winchell for outward signs of hypoxemia. You must know what hypoxemia is. It is in your PowerPoint. This is a decreased amount of blood, of oxygen in the blood. The nurse notes that the African American's thoracic skin color is dark brown, consistent with ethnicity, and what additional assessments will provide supporting data related to hypoxemia. And of course, that was also in your PowerPoint, and the answer is the color of palms and soles and nail beds. Okay? All right, the next question is, the nurse reviews landmarks on the anterior chest and locates the angle of Lewis. Locating the angle of Lewis is important to guide the nurse in locating what area next. So the answer to that is the second rib. Okay, I want you to go over these landmarks. I'm not going to talk a lot about it in person, but even these choices, think about where the xiphoid process is. Where's Erb's point? Where's the clavicle? And where's the second rib? Because a lot of the ways in which we determine those landmarks, especially when we're doing looking at and listening to a cardiac assessment, is to look at those different landmarks to know that we're putting the stethoscope in the correct position if we want to auscultate sounds from the aortic valve, the mitral valve. And this is what this week's lab experience is all about, making sure that we're getting the landmarks correctly. Okay, let's go to the next question. Mr. Winchell asked to sit on the side of the bed. After assisting him to this position, the nurse continues the assessment facing Mr. Winchell's back and placing both hands on the posterior lateral chest at the level of T9. That's thoracic 9. To assess chest excursion, what should the nurse do? Again, to find out this information, you would definitely go to your D'Amico and Barbarita to see how you would do that. All right. We are not going to do this in our head-to-toe assessment, but I think it's important to know how would we kind of assess chest excursion and expansion. And the answer to that is think about it. We would ask the patient to inhale deeply because we're looking if this patient has symmetrical expansion and excursion, okay? And look, it's very important that we place the hands at the correct level, and that would be down there at thoracic 9, okay? And you can count out those ribs posteriorly to be sure that you are putting it in the right spot, okay? And you might want to look on the skeleton. We have a skeleton in the lab, and sometimes that really helps you to point out those different landmarks, especially when we're talking about the rib cage, okay? Without all the tissue around, it's much easier to say, okay, let me think where T9 is. Oh, wow, it would be all the way there or down there, okay? So now the nurse observes some symmetric chest excursion, which is a good thing. What actions did the nurse take, okay? And what she would do was to document the normal findings on the assessment record. All right, the next question is vocal fremitus. The nurse next plans to palpate for vocal fremitus, recalling the patient's admission diagnosis of acute pulmonary infection. What findings should the nurse anticipate? Okay, remember what fremitus is. You have to know what vocal fremitus is, and that's a fremitus that we're going to determine by when the patient speaks. So what is fremitus all about? So I want you to go back and read that, and if you have any questions, please let me know. I explained it somewhat in the PowerPoint. The answer to that would be increased fremitus over areas of consolidation. Consolidation are areas where there's fluid, and so we're going to have increased fremitus because sound travels better through fluid. And so that's why your fremitus at this point would be increased, okay? If that doesn't make any sense, I want you to read it over, and then we'll talk about it in class on Wednesday, okay? To begin the assessment for vocal fremitus, what should the nurse do? And the answer to that is ask the patient to repeat a phrase aloud, and sometimes it's 99. So those are various words that the patient can use when we're talking about vocal fremitus. So that's what that's about. So if you're not sure about that or that doesn't make any sense, watch some YouTube videos on fremitus. They have some really good ones. That's how I really could learn a little bit more, so it would seem a little bit more simple to me, and even just to teach it, because sometimes the book isn't always clear as to really what is happening when that assessment is made. So just Google vocal fremitus and how to assess, and you'll see various little snippets of some YouTube videos, which could be very, very helpful for you if you're not getting the full meaning from your reading, okay? You've got to know this. It's going to be on the test, all right? So I want you to understand this. I told you this is not an easy system, but these are assessment findings and ways in which we assess our patients to determine if they have a lot of fluid or not a lot of fluid, or it can also lead us to what the patient's actual medical diagnosis is. So since Mr. Winchell is still comfortable sitting on the side of the bed, leaning over a bedside table, which is a very frequent position we see these patients sit in, the nurse next prepares to percuss the patient's thorax. Now we're not going to percuss, but we know what that's about. It's she percusses the patient's thorax posteriorly, beginning at the apex at the right lung. And how should the nurse begin? So you need to know where the apex is, and so the first thing we're going to do is locate the patient's first intercostal space. Okay, so that's how we percuss. Apex is up there, kind of up there around by the scapula area. So definitely look at that when we point out different landmarks on the chest or the back, what those mean. When we say the apex of the right lung, where is the apex of the right lung? All right, next, the nurse percusses the lungs, patient's lungs bilaterally, and notes dullness in the lung bases. What follow-up action should the nurse implement? Now we're going to, compare the findings with the location of the patient's pneumonia on X-ray. And because we talked about an infection, it has been diagnosed that the patient does have pneumonia, okay? All right, so dullness would be expected because there's fluid there in that lung. Remember, we talked about consolidation, and that's what would be the reading back on the patient's chest x-ray. You may not know a lot about chest x-rays, but obviously with a respiratory patient, we're always going to do a chest x-ray to get that baseline and then sometimes compare that chest x-ray. Maybe Mr. Winchell was in the hospital a few weeks ago or a couple months ago. We're going to look at that last chest x-ray he had and make that comparison. Are things deteriorating? Do things look about the same except for the fact now he's got some pneumonia present? Always make sure you follow up and look at that reading. Many times now with electronic medical records, you can actually bring the picture up to the screen and kind of look at it. We're not trying to make radiologist out of you, but as a nurse, I like to know if I can pinpoint anything on the patient that's truly significant. I like to see where that consolidation is so that I can work maybe on some pulmonary hygiene to help patients that have fluid or whatever in a certain area of the lung, to do some of those interventions to help your patients decrease some of that fluid and help heal up their infection. Okay. All right, next, Mr. Winchell remains seated on the side of the bed. The nurse begins to auscultate his breath sounds posteriorly, placing the diaphragm of the stethoscope over his left lung apex. After listening in this area, how should the nurse proceed? Well, now we're going to move the diaphragm across to the right lung apex posteriorly. Hopefully you get the direction of how to move your stethoscope when you're listening to those 10 landmarks posteriorly, because that's how many times you're going to listen. You've got to be very careful, though, as you tell your patient to take a deep breath in. You must, leave it there a few seconds, so if you're hearing anything unusual, then you move on to the next landmark and you just keep going down and across, down and across. Your instructor should show you that today with your lab and know how to proceed to listen to the patient posteriorly. Be careful that the patient isn't breathing too fast in between the different positions that you are using to auscultate his lungs, because sometimes they can get a little bit dizzy and you don't want him to be blowing off too much CO2. But the answer to that question is move the diaphragm across to the right lung posteriorly, okay? And if you have any questions, ask your lab instructor today. This is what they're there for. They're very much experts on this, and they can help you with your auscultation of your lungs today, okay? The nurse hears vesicular breath sounds when auscultating over the upper and middle lungs posteriorly. What action should the nurse take? So right here we've got a particular type of breath sounds that we're hearing, and you want to think about what is a vesicular breath sound when auscultating. I'm not going to tell you because you should get that from your PowerPoint. You might want to go back. Is that an adventitious or is that a ventitious breath sound? So, auscultate that lower lung field to determine the presence of any adventitious sounds, okay? So the question is it a normal or abnormal breath sound when we talk about vesicular? Not going to tell you. I want you to critically think that one out. So the nurse hears crackles bilaterally in the posterior lung bases. So again, what are crackles? What does that signify? Okay, so she hears them. What about it? So you might want to think about that. And maybe if you heard these in the afternoon, you might want to think about it. Did I hear these this morning? Well, if you didn't, then obviously now the patient has developed crackles. And so what are you going to do about it? This is hopefully this video clip on adventitious breath sounds works. I'm going to check it when I'm done here. But after the nurse completes auscultation of the breath sounds posteriorly, Mr. Winchell states he is ready to swing his legs back on the bed and rest. The nurse assists the patient in a semi-Fowler's position, ensuring that his oxygen remains in place. And as you can see, this is the position that makes him comfortable and makes it easy for him to breathe. Make sure he has his call bell, make sure his oxygen is on the desired flow rate that has been ordered, and make sure that if he has tissues, that they're nearby and that he's comfortable, and that if he needs you for anything, to definitely call you as his nurse, okay? All right, so Mr. Winchell is resting in bed in a semi-Fowler's position. Think about what angle that would be, and I discussed that on nursing interventions. I'm not going to go into that again. So the nurse auscultates the breast anterior. You are going to be doing this as well. So the nurse hears high-pitched musical squeaking sounds in the upper lobes during expiration. Think about this. You want to go, wow, is this normal or is this abnormal? So what action should the nurse take? Very good question. Let's see how good you understand all that information that was given to you in the PowerPoint. So you would document the presence of wheezes. That's how we describe or define a wheeze in the upper lobes and complete the assessment. And think about it too. Why does a patient develop a wheeze? What's the underlying reason? And that's what I want you to think about and tell yourself as we continue through this case study. Okay, these are great questions. Kind of assess your learning from your reading and from what you gathered from that PowerPoint. The good thing is now you have that PowerPoint. I've downloaded that in Canvas along with those two lectures, and you can listen to those anytime, okay? And you can use that PowerPoint as a baseline for notes from the reading that was assigned, and then as you read you may want to add additional notes that give you that information. I'm going to tell you, now that PowerPoint was given, I've given these lectures, we're going over this case study, you're going to see some of the very same questions. So I want you to understand it though. This is huge when it comes to assessing our patient's respiratory status. This is such a big system. It's about oxygenation, okay? So next question. Although crackles could be heard bilaterally during the posterior auscultation of the lung bases, the nurse does not hear any adventitious sounds in the lung bases during anterior auscultation. What action should the nurse take? And the answer to that would be C. Chart what was heard both anteriorly and posteriorly, and that's all you can do, okay? I always like to listen to the patients posteriorly. I wasn't one to always listen to my patients anteriorly. I felt that you could hear the cardiac sounds, and it kind of interfered with some of the sounds, and I didn't get a good hearing of exactly what was going on in those lungs. I really think posterior auscultation, sometimes you can hear things a lot better. But we do want to teach that many times because of the patient's situation, we can only auscultate anteriorly. All right. Later that day, the UAP reports a change in Mr. Winchell's vita signs with an increase in temp from 101 to 103 Fahrenheit. The UAP reports the information to the nurse who goes to the patient's room to assess the patient. The nurse observes sputum in a tissue left at the bedside. The sputum is thick and purulent. What assessment should the nurse perform? This is extremely significant. Now the patient has developed a fever, and it's pretty high. It's 103. And so you have to think about, okay, there's probably some infectious process going on or continuing, plus think about how fast this patient can dehydrate if he's not drinking. So the nurse does need to go in there and assess the patient again. And now she observes that he does have sputum, and so it's thick and purulent, and right away I would think, oh my goodness, this could be a barrier for my patient to receive proper oxygen, so I'm very concerned. It doesn't tell us what color, but sometimes color can tell us some very specific things about your patient. So now what should the nurse do, okay? The best thing is to auscultate those breath sounds again, okay? Has that changed? Because remember, we did hear crackles before in the bases. So what data is most important for the nurse to obtain before contacting the health care provider? And so now she, excuse me, she should call the health care provider and really have a SBAR type of reporting, because they're going to ask you a whole bunch of things. Maybe you might want to call the house doctor or hospitalist. Maybe we need to get a repeat chest x-ray. Maybe we would want to do blood gases again, because maybe this patient is really showing signs of really some very significant respiratory distress. Maybe now his respirations are up to 42. So these are things that you will have to make that decision, because we don't want this patient getting into more trouble, because a lot of times, they really can go downhill very quickly. And again, as we assess that respiratory status, we're looking at his cardiac status. Probably with all the coughing, We put a lot of stress on the cardiac system. Their heart rates are up. This is where sometimes the patient who's having respiratory difficulties with this chronic disease, has this respiratory infection, really starts to develop cardiac issues such as irregular heartbeats and things like that. So we cannot just focus only on the respiratory system, because things that happen within the respiratory system may affect your patient's cardiac status as well. What's his blood pressure? What's his heart rate? Is he having chest pain? Because sometimes with increased heart rate and the stress that this infection has on the body, the patient may start to develop chest pain. So these are things that you want to really keep into mind. So what are we going to look at? His respiratory effort, okay? All this is important. Peta pulse volume, orientation may tell us about his level of consciousness, but really it's about how is he breathing? Is he using those accessory muscles? Is he really have to lean over the side of the bed? All those things are really pertinent. Okay, the nurse documents the assessment findings and prepares to contact the client's healthcare provider. So when recording the changes in the patient's assessment findings, how should the nurse document the breath sounds? And of course, she would document that crackles were heard bilaterally in the middle and lower lobe fills posteriorly. So now that fluid is really advancing upward. We heard them in the bases and now they're in the middle lobes. This is serious. The patient is really developing respiratory distress because he has increased fluids in his lungs, okay? So we would probably get a chest x-ray, maybe change his oxygen, do ABGs, and maybe give him diuretics or whatever. I don't know for sure what's already been ordered for the patient. Okay, the next question: how should the nurse report the assessment data? A very, very good. A very good question. We would compare the current assessment of the patient to the data obtained during the admission assessment. So how has this patient changed? Because remember, he does have a chronic respiratory problem, but he didn't come in that way, and now his condition has worsened. So we find that very significant. So do you see the difference? We have to look at this patient specifically, okay? So that concludes this case study. I hope, again, things were picked out that make sense to you. You might want to go over some of these terms within this case study to be sure that you understand them. Again, review that PowerPoint, maybe highlight some of the important terms, but just don't memorize the terms. Think about, okay, what is the significance of this during an assessment? What does this mean when a patient has increased fremitus? Are all the patient's respiratory structures intact, starting from the nose all the way through the lungs? Let me think about, how the lungs are made up and how oxygen and diffusion of gases takes place. You haven't had, the pathology concerning a patient with emphysema. You won't get that to Nursing 122. But I think it's significant that you understand a little bit because I'm sure you're taking care of some of the patients in your particular facility that maybe have some respiratory ailments, and so it's important to understand what the pathology is behind that. Because with a patient like Mr. Winchell, he has COPD, and that really affects the alveoli. That's where the disease is at. So, of course, that's where all the diffusion of gas exchanges takes place. So when we have those structures and that vascular membrane all diseased, patient's going to have a compromise in his diffusion of gases, and that's why we have low oxygenation and high levels of retention of CO2. So this is just a great way to kind of put the pieces together and to kind of find out what exactly is going on with your patient. So I hope you found this helpful. This is downloaded in your Canvas course, and hopefully you've been following me along. If you have any questions about why you think that's the answer and something isn't the answer, give me we can talk about it on Wednesday when I come back, okay? So hopefully now you have enough to do. You have all the important information, just as if we would have had class today. It is a little longer than 2 hours, but I really think it's important that you get this extra bit of learning, and I've spent quite a few hours now taping this for you. So I wish you all the best, and we can discuss this if you have any questions, and then we'll proceed on Wednesday with the cardiac system, learning about the concept of perfusion. Have a blessed day, and I'll see you soon.